welcome to the fourth webinar in our breast health series. In our previous videos, we talked about screening mammograms, high-risk assessment, and diagnostic imaging. You can see our series by clicking the button on the screen there for more information or scan the QR code. Today we're talking about breast biopsies. Our radiologist and breast surgeon panel walk us through the procedure from beginning to end, show us what to expect, and then discuss what the pathology results mean for a patient. Let's hear what they have to say.
Hi, my name is Dr. Nicole Nelson. I am the medical director at the Women's Wellness Center at Mercy Health St. Rita's in Lima, Ohio.
So Dr. Nelson, we're going to talk about biopsy, and there is a needle biopsy. There's also an open surgical biopsy that some patients might be recommended for. Could you explain the difference of what is a needle biopsy versus somebody that's recommended for an open surgical biopsy?
All of the governing bodies tell us that the largest percentage of our biopsies should be a needle biopsy, a core needle biopsy, whether it's done by a radiologist or a surgeon. Open surgical biopsies are no longer the standard of care. That being said, there are some people who still need to have an open surgical biopsy, and usually by the time the patient gets to a surgeon for an open biopsy, they are already aware of the fact that for whatever factors are unique to them, they aren't eligible for a stereotactic biopsy or an ultrasound-guided biopsy. When we do the core needle biopsies under imaging, whether that's mammography, MRI, or ultrasound, it's much easier on the patients. They're not sedated, so they're allowed to eat, they're allowed to drink, they're allowed to take their medications, and they're able to work after our procedures.
Hello, my name is Dr. Kimberly C. Hutcherson. I'm a board-certified, fellowship-trained diagnostic radiologist specializing in breast imaging. I am the medical director of breast imaging at Northside Hospital Gwinnett in Lawrenceville, Georgia, and Northside Hospital Duluth in Duluth, Georgia.
So Dr. Hutcherson, when a patient is recommended for a biopsy, often the first thing they think of is cancer. And so they worry about the results and have a lot of anxiety about that. What would you say to these patients before they come in for their biopsy while they're in that waiting period?
So actually the day of the diagnostic mammogram, when a patient is recommended to have a biopsy, at that time I discuss the findings that I see. There are possibilities of what this could be. It could be a benign process, but it also could be atypical cells or a malignant process. Because of this latter two, I'm recommending that we do a biopsy. The procedure that we do is minimally invasive, and the results are available within 3 days following the biopsy. It's hard not to worry about it, but try not to be too concerned with it at this time, because right now we just need to determine what that process is. And if it's benign, hopefully that it is, then we'll just place you back in an annual mammogram.
One of the things that we often hear that patients are concerned about with the biopsy during the process is if it might hurt for them to have the biopsy. Can you explain a little bit about what you do to prevent that pain and what the experience might be like for the patient?
Sure. So at the time of the biopsy, we always use local anesthetic to anesthetize or numb the area where we're going to perform the biopsy. I actually administer a little lidocaine that's buffered with bicarbonate actually on the skin first, and then patients don't really feel that initial prick. We numb the skin up very well. We actually numb underneath the mass or around the mass or through the calcifications, and give enough anesthetics that do not feel any discomfort during the procedure. And with the particular type of needle that I use, it is a single insertion device. So I'm not going in multiple times. I'm just placing it once through the lesion, underneath the lesion, and then we take several samples, small samples, we vacuuming out or suctioning out those pieces of tissue. And then we leave a small marker there, the tissue marker or biopsy clip. It marks that cavity so we know exactly where we were at the time of the biopsy. Once the procedure is done, we just hold pressure, make sure there's no bleeding, place small steri strips over the puncture site, no sutures required. Again, it's minimally invasive, and we place a Band-Aid over that particular site.
So Dr. Nelson, during the biopsy, you leave behind a little breast tissue marker. Can you explain what the marker is for and why it's so important for you to leave that behind?
So at the time of any biopsy, we always put a small marker clip at the biopsy site. And we do this in all patients. After a year or two or 5 years or 10 years, it's very common for patients to say, I had a breast biopsy a long time ago, but I don't remember which breast it was in. If there's a marker in it and the patient said, oh, I had a benign breast biopsy years ago, we can see a nodule, we see a clip in it, that makes sense. We don't have to do any further investigation of that spot. If it is something suspicious or it is a cancer, we need the marker clip in place to guide the surgeon to that spot so they can take it out. The other category of patients that we like to have that marker in, let's say it's a cancer and the individual, because maybe a larger cancer or due to the type of cancer, they're going to get chemotherapy first. So they're getting chemotherapy before surgery. We certainly need a marker clip in place because sometimes that chemotherapy will completely erase or completely treat the cancer. The tumor is gone after chemotherapy, but standard of care is still that area is taken out surgically. So we certainly need a marker clip in place in those individuals because we won't be able to find the spot back.
So I'm Dr. Christine Ormsby. I'm currently practicing in Festus, Missouri, which is just outside St. Louis. I kind of rotate from site to site.
Dr. Ormsby, probably the number one question that we hear from patients about breast tissue marker that's left behind is, will they have any trouble if they fly in the future and go through an airport detector, or will it cause any discomfort in the future? Can you speak a little bit about that?
Most markers are made of titanium. It will not set off a metal detector. These are MRI safe. And actually, titanium is the same type of metal they use in joint replacements. It's very safe to leave in the body. I've never had a patient have an allergic reaction. They are very small. The patient will not feel it. And it's extremely important that we put these in there. If this were to come back as something we need to take out surgically and we didn't mark it, then it puts us in a very difficult situation if we're unable to find that lesion again. So it's really important that we have that in there. It won't cause any harm to the surrounding tissue, and we need to make sure that we can find that area again.
And so can a patient resume their normal activities after the biopsy? Are there any restrictions?
Very shortly after. We usually say not to shower for a day or so and no heavy lifting for a day or so. Anything that gets too strenuous can increase that blood pressure and can run the risk of any kind of oozing after the site. But it's a very low risk procedure. There's really no harm that the patient can do from going home. We really don't want the patient to do anything too strenuous because if they were to have any bleeding or oozing at that site when they go home, it just makes it more tender.
So when a patient comes in for a biopsy, can you explain what the possible outcomes of that tissue biopsy will be?
So when a patient has a biopsy, I look at kind of three different outcomes, three different categories of outcomes for a biopsy. At one end, we have benign or non-cancerous lesions, things like cysts or fibrocystic changes. These are typically lesions that we can leave alone and not worry about. At the other end, we have cancers. And of course, cancers typically need to come out surgically. What people often don't know about or don't think about are things in the middle, which are called high-risk lesions. High-risk lesions are things like what's called atypia or atypical lesions. These are things where the cells aren't quite normal, but they could increase our risk of cancer down the road. And these are things that need to come out surgically because sometimes actually when we take them out surgically, we may find actually that there are small cancer cells in the specimen. Other things in this group are things called radial scar, papillary lesions. These are things that we need to take out surgically because they increase the risk of cancer for the patient down the road. So anything in that high risk group or anything that is found to be cancerous on the biopsy would need to come out surgically.
Hi, my name is Barry Rosen. I'm a breast cancer surgeon in practice in the northwest suburbs of Chicago.
So Dr. Rosen, after a patient has a breast biopsy, they receive their results. Some of the more common benign pathologies are either a breast cyst or a fibroadenoma. Can you talk about what those are and what a patient can do to manage those?
Sure. So when we deem a mammographic abnormality worthy of biopsy, we have a term for that. We call it suspicious. If we think something is suspicious and warrants a biopsy, it ends up being cancer only about 25 to 30% of the time. So overwhelming majority of the time when a woman is told they need a biopsy, it's going to end up benign. Most common benign tumor that we find in the breast is a fibroadenoma. And if a fibroadenoma is not enlarging and not causing pain, it does not need to be removed. There are what we call high-risk lesions though. So sometimes we'll see atypical cells. The term that we use is atypical ductal hyperplasia or atypical lobular hyperplasia. Sometimes we actually have to go back and remove more breast tissue just to be 100% certain that it's not a cancer. But what's especially pertinent about those results is that that is an independent risk factor for breast cancer. So if a woman is found to have what we call ADH or ALH, they should go to a high-risk clinic or see a breast surgeon to talk about what measures can be taken to reduce their risk and to do closer surveillance based upon those results. There's another very common result called an intraductal papilloma. I think of a papilloma, it's like a polyp of the breast duct. And we often will still need to surgically remove the entire papilloma to be 100% certain that it's not a cancer. But there's more and more studies that are being done that say that we can watch some of these. So if you're found to have a papilloma, you definitely need to see a breast surgeon, but you don't necessarily need breast surgery.
When a patient hears that they need a biopsy, in their mind, they instantly think cancer. Can you talk through the statistics of how often that biopsy result comes back as something that's benign versus something that's not?
So most biopsies are actually benign. So about 4 out of 5 or about 80% of our biopsies that we do are actually benign.
So most breast biopsies that we do are in the breast, but sometimes there's something that we see or feel that we need to look at in the axilla or the armpit area. Could you talk through why there would be a need for a biopsy in the arm area and what that would mean for a patient?
So if we biopsy in the axilla or the underarm region, we're looking for basically 2 main things. What we're looking for is sometimes breast cancer can spread to the underarm region, and sometimes we can also pick up other cancers of the lymph nodes, something like lymphoma.
When scheduling your breast biopsy, either a radiologist or a breast center staff member will explain the results of your diagnostic imaging and what type of biopsy you will have. Breast biopsies are typically performed with either ultrasound or mammography, but sometimes a patient will have an MRI-guided biopsy. If your biopsy requires the use of mammography, that is called a stereotactic biopsy. These can be performed either laying face down on a biopsy table or sitting up in a chair, depending on what the facility uses. Your breast will be placed in compression, similar to a mammogram, but with a much smaller paddle. If you are having an ultrasound-guided biopsy, then you will be lying on your back and most likely raise your arm over your head and roll slightly to your side during the procedure. It's important to take the time to get comfortable and make sure you can hold still in that position before the biopsy starts. Work with your technologist to add padding under your legs and arms or a pillow behind your back. These steps will ensure your comfort and help make the biopsy a smoother process. After the radiologist has taken the small pieces of tissue for the pathologist, they will leave behind the tissue marker. You will have a post-biopsy mammogram to allow the radiologist to see the marker in place in comparison to where the tissue samples were taken. These mammograms require much less compression than your screening or diagnostic mammograms. A tissue marker will be left at the site of your biopsy to mark the area for 2 reasons. If your results are benign or normal, then it will help a radiologist to know exactly where you had a biopsy when looking at your future mammograms. If the results are atypical or malignant, the marker helps a surgeon know exactly where the abnormal tissue is when planning your surgery. These markers are about the size of a grain of rice, so you won't be able to feel it inside your breast, and you can go about your daily activities as normal. After your procedure, you will be given instructions on how to care for your biopsy site. You will be asked to wear a supportive bra and use an ice pack for a short time. Most patients can return to work and most daily activities right after the biopsy. But be sure to ask any questions you may have and know how to contact the facility once you're home. It could be several days before you'll receive your biopsy results. If the results are benign or normal, you may be asked to come in for a mammogram or ultrasound in about 6 months for a short-term follow-up. If the results are atypical or malignant, the radiologist will recommend that you see a breast surgeon. Your doctor or the breast center will help you schedule this appointment and provide you with all the information you need to develop a treatment plan. Thank you for joining us today as we explored breast biopsies. We hope you find the information valuable. We do have downloadable resources for you if you'd like more information. Don't miss our next episode as we address breast cancer surgery and the options that you have as a patient today. You can scan the QR code on your screen or click the button for more information to see our entire breast health webinar series. Thank you for joining us. We'll see you next time.